Okay, maybe we can go ahead and start.
Okay.
Are you ready?
Yep. Yep. Good morning, everyone. My name
Can I
is
introduce you
Ifrah.
first? Is that okay?
Yeah, go ahead.
I wanted to introduce to everyone Dr. Zawar. We've been actually talking for at least a couple of weeks on the phone and via Zoom. I'm happy to tell everyone that we're, considering Dr. Zawar, and she's really interested in our epilepsy position. I had great interaction with her, and she has a special interest in neuroimmunology. She has been at Cleveland Clinic since 2014, completing residency and a 2-year epilepsy fellowship. And we'll have the first grand rounds in epilepsy, neuroimmunology, and epilepsy. So let's welcome Dr. Zawar.
Thank you. Thank you. Good morning, everyone. I'm Ifrah, and today I'll be talking about neuroimmunology in epilepsy. So I'll discuss the role of autoimmunity in epilepsy and the pathophysiology of autoimmune encephalitis and epilepsy. I'll discuss different subcategories of encephalitis and epilepsies of autoimmune origin. I'll discuss the risk of chronic epilepsy in various types of autoimmune encephalitis and seizures of autoimmune origin. Then I'll just briefly go over the clinical presentation of a few different types of autoimmune epilepsies. I'll discuss the clinical approach to the diagnosis of autoimmune encephalitis. Then I'll discuss the prevalence of autoimmune epilepsy among epilepsies of unknown etiology and the diagnostic evaluation and the treatment approach to autoimmune epilepsy. So with that, I would like to start with epilepsy of immune etiology, which is a newly recognized term by International League Against Epilepsy in their 2017 classification. Epilepsy of immune etiology is an epilepsy that results directly from immune disorder, in which seizures are a core symptom of the disorder, and there is evidence of autoimmune-mediated CNS inflammation. It is also known as autoimmune epilepsy or autoimmune-associated epilepsy. This is just restating the same thing from the ILE classification. This epilepsy classification has been termed recently. So before moving forward, there are two important definitions that I would like to emphasize on. Seizures are very frequent in the acute phase of autoimmune encephalitis, but most of them will recover after encephalitis resolves. It is frequently assumed that if a patient is having seizures and they have antibodies in their serum or CSF suggestive of autoimmune encephalitis, they have autoimmune epilepsy. However, seizures in the setting of autoimmune encephalitis does not mean the patient has autoimmune epilepsy. So with that in mind, ILE Task Force has proposed two important definitions recently in May of 2020. Acute symptomatic seizures secondary to autoimmune encephalitis, which refers to seizures occurring in the setting of the active phase of immune-mediated encephalitis, and autoimmune-associated epilepsy, which refers to chronic seizures or epilepsy determined to be secondary to autoimmune brain diseases. Now, the pathophysiology of autoimmunity is basically our immune system has T and B cells, as we all know. Sometimes the body may mistakenly recognize part of itself as foreign, resulting in activation of B cells, which then form plasma cells, which then form antibodies, and activation of T cells, which can lead to cytotoxic CD8 positive killer cells. And both of these antibodies and cytotoxic killer cells may work against our autoantigens, resulting in autoimmunity. Sometimes tumors or viruses can cause proteins from neurons to be exposed to the immune system, resulting in autoimmunity. So on the basis of their cellular location, the autoantigens with respect to autoimmune epilepsies or encephalitises can be divided into two categories. So one of them is neuronal cell surface or plasma membrane autoantigens, and the other is intracellular autoantigens. So when surface antigens are exposed to the immune system, that will result in B or plasma cell activation, resulting in antibody production, which will then bind to the surface antigens, interfering with their function. When intracellular autoantigens are exposed, antibodies may be produced, but they these antigens cannot be accessed on the surface by antibodies because they're present within the cells. So the immune system typically in these cases will activate CD8 positive cytotoxic T cell response, which will then attack or kill neurons. And both of these phenomena can result in seizure development or epilepsy development. So this slide just states the same thing that discussed. Tumor or infection can be potential triggers for autoimmunity. They can lead to misdirected immune response to self-antigens contributing to neuronal dysfunction. And these are two different ways in which that may happen. I'm going to skip that. So epileptogenesis, irrespective of whether it is of autoimmune origin or any other type of epileptogenesis that leads to epilepsy, has two broad pathways that it may follow. So epileptogenesis can be ignited by brain injury and infection, which can result in release of pro-inflammatory cytokines, astrocyte activation, upregulation of cytokine receptors, induction of COX-2 prostaglandins, upregulation of complement systems, activation of perivascular glia, increased blood-brain barrier permeability, and all this pathway can then eventually, with the induction of seizures, this pathway can eventually lead to epileptogenesis by synaptic receptor dysfunction, plasticity changes, and hyperexcitability. Inflammation is the other broad pathway that can lead to epileptogenesis. So inflammation will result in cytokines being released in the system, which can alter transcriptional and non-transcriptional pathways, in turn resulting in synaptic receptor dysfunction, plasticity changes, and hyperexcitability. Just like any other type of epilepsy, antibody-mediated encephalitis can follow either of these pathways, resulting in the development of epilepsy. But even independent of these two pathways, antibody-mediated encephalitis can lead to direct antibody-mediated alteration of the corresponding targets, resulting in epileptogenesis. Now I would like to talk a little bit about the epidemiology. So autoimmune encephalitis has an incidence of 0.8 per 100,000 person years and a prevalence of 13.7 per 100,000 people. There has been a significant increase in the incidence of autoimmune encephalitis in the last decade, which is perhaps because of increasing recognition of this. As far as the autoimmune associated epilepsy is concerned, incidence is unknown. However, we do know that epilepsy of unknown etiology accounts for 1/3 of all epilepsies. And there are various studies that have shown, that I'm going to talk about later in this talk, that anywhere from 10 to 25% of adult epilepsy patients of unknown etiology may have antibodies associated with autoimmune epilepsy. So if we do the math, it can be extrapolated from these two facts that antibody-positive autoimmune epilepsies account from 5 to 7% of all adult epilepsies. These are the various antibodies that have been discovered over the past several decades. So we have come a long way in this specific subspecialty. When I think about autoimmune-associated epilepsy, there are 4 major subcategories in which I like to divide them in my head. A lot of the times people, when they're talking about autoimmune-associated epilepsies, they're talking about antibody-positive autoimmune-associated epilepsies. But we should also keep in mind that patients can also present with antibody-negative autoimmune-associated epilepsies. And then there are epilepsies and systemic autoimmune disorders, and then there are terms such as NORS and FIRES that we need to be familiar with in the context of autoimmune epilepsies. So antibody-positive autoimmune-associated epilepsies can be further divided into antibodies against intracellular antigens. These epilepsies are T-cell mediated, and antibodies can be against surface antigens, and in these cases, these epilepsies are antibody-mediated. And it's important to know the difference between T-cell mediated and antibody-mediated, because it drives the prognosis and the management for these patients. So intracellular antibody-positive epilepsies are the classical paraneoplastic syndromes that can include GAD65, anti-HU, anti-RE, anti-MAT2, CRMP, and GFAP antibody syndromes. I'm not going to go into the detail of these syndromes. The more important thing to remember is that these classical paraneoplastic syndromes have neuronal nuclear or cytoplasmic antibodies. So they are located within the cells. And because of that, the immune response is cytotoxic T cell mediated, because of which these patients have prominent brain infiltrate with T cells. They may have antibodies present, but they are not pathogenic, but they can be useful disease biomarker. So overall, because this is cytotoxic T cell mediated, they have a poor overall outcome. They have limited response to immunotherapy, and they have a high risk of recurring seizures and epilepsy because these T cell can cause permanent damage, and there's a higher risk of developing chronic epilepsy in these patients. Surface antibody mediated epilepsies, again, there's a huge list and includes NMDA receptor encephalitis, voltage-gated potassium channel syndrome, LGI1, Casper2, GABA-A, GABA-B, EMPA receptor, and some other that I'm not going to go into the detail of. Just that these are the non-paraneoplastic syndromes. Antibodies are pathogenic in these cases, so they are called antibody-mediated encephalitis. Initially, these patients can have really severe symptoms, but they typically have a good response to immunotherapy. And the seizure severity and the likelihood of epilepsy development in the chronic setting is typically on the lower side, although it depends according to the antigen. So most of these will have chronic epilepsy develop in less than 5% of the patients. So this is just a slide looking at the risk of epilepsy in these surface antibody-mediated epilepsies. So LGI1, GABA receptor, GABA-A and GABA-B receptor syndromes can have chronic epilepsy development anywhere from 15 to 30%, but for all the other syndromes, the probability is fairly low. This just states the same thing. And then moving on to the presumed autoimmune epilepsies or antibody negative epilepsies, basically patients are presumed to have antibody negative autoimmune epilepsies if they have idiopathic seizures and there is evidence of inflammation in the CSF, but they don't have any antibodies either in the CSF or serum. And then in addition to that, antibody negative epilepsy is another classical one that falls under this autoimmune epilepsies is Rasmussen's encephalitis, in which patients present with refractory seizures, unilateral brain atrophy, hemiparesis, and these patients are really, really refractory to antiepileptics, and most of them will end up requiring hemispherectomy. Then this slide I put in just to emphasize that in the acute symptomatic phase of autoimmune encephalitis, patients can have, in addition to antibody negative encephalitis, the antibody positives, one can either have antibodies against surface antigens or intracellular antigens like we discussed. But when you're looking at patients with autoimmune associated epilepsy in the chronic setting, these patients are more likely to have intracellular antibodies because these are the patients who are more likely to develop chronic epilepsy. And then Rasmussen encephalitis is the other one, which is refractory and more likely to be encountered in the chronic setting. For the systemic autoimmune disorder, I'm not going to go into the detail of these disorders. The only thing that I wanted to emphasize was that patients who have systemic autoimmune disorders have a high risk, high frequency of seizures. So SLE patients can have up to 40% of these patients can have seizures. Hashimoto's encephalopathy, up to 66% of these patients can have seizures. And even with other systemic autoimmune disorders, they're at a higher risk of developing epilepsy and seizures compared to the general population. Just emphasizing the role of autoimmunity in epilepsy. And NORS and FIRES are two important terms that are used in the context of acute presentation of status epilepticus with frequently presumed autoimmune etiology. So I just wanted to familiarize everyone with the definitions of these terms before moving forward. So NORS stands for New Onset Refractory Status Epilepticus. It is a clinical presentation, not a specific diagnosis in a patient without active epilepsy or other pre-existing relevant neurological disorder with new onset of refractory status epilepticus without a clear acute or active structural, toxic, or metabolic cause. And 40% of these patients can have confirmed autoimmune etiology, although a lot of other cases are also treated as such. And then 30% of these patients can develop chronic epilepsy. So the risk of development of chronic epilepsy is not low. And then FIRES or febrile infection-related epilepsy syndrome is a subcategory of NORS applicable for all ages that requires a prior febrile infection starting between 2 weeks and 24 hours prior to the onset of refractory status epilepticus, with or without fever at the onset of status epilepticus. And again, a high percentage of these patients are likely to have autoimmune etiology. I mean, they can also have just an infection that led to refractory status epilepticus, but even autoimmune etiology patients can have a viral prodrome or fever before they develop refractory status epilepticus. So for the clinical presentation, I'm not going to go into the detail of individual syndromes. I think it's more important to understand them in two broad categories and understand their general presentation. A few distinctive features. So most of them, these patients have limbic encephalitis kind of presentation, which I will discuss shortly in the diagnostic criteria of autoimmune encephalitis and epilepsy. But some of these more commonly encountered ones can have certain distinctive features in addition to limbic encephalitis. So LGI1 autoimmune antibody syndrome can have faciobrachial dystonic seizures, piloerection seizures, and hyponatremia. These are some of the distinctive features that may be used to identify these patients as LGI1. NMDA receptor encephalitis can have oral dyskinesias, catatonia, and like strong autonomic dysfunction, and autonomic lability is frequently seen. GAD65 patients can have hyperplexia and brainstem encephalitis kind of a picture, in addition to limbic encephalitis. I am not going to go into the detail of the rest in the interest of time, but just that most of these syndromes have a limbic encephalitis kind of presentation. So that I'll discuss now with the clinical approach to the diagnosis of autoimmune encephalitis or the presentation of limbic encephalitis. Clinical picture, these patients, if we encounter patients with subacute onset of memory deficits and altered mental status, obviously these patients are considered for the possibility of autoimmune encephalitis, and therefore at the minimum these patients should undergo an MRI, EEG, and an LP study. So the diagnostic criteria for possible autoimmune encephalitis has three criteria. The first one is
We're getting like this, like a lecture type deal.
Pardon?
You can continue. I think it was a mistake.
Okay. So subacute onset with rapid progression of less than 3 months of memory deficits, altered mental status. In addition, these patients need to have one of these four criteria. So either new focal CNS findings, unexplained seizures, CSF white count of greater than 5, MRI features suggestive of encephalitis, which are typically unilateral or bilateral flare mesial hyperintensities, and then exclusion of other causes such as causes of rapidly progressive dementia and CNS infection. So if these three criteria are met, then patients possibly have autoimmune encephalitis. The definitive criteria for autoimmune limbic encephalitis has 4 things that need to be met. So they need to have subacute onset of symptoms. In addition, they need to have bilateral mesial temporal flare hyperintensity. And in addition, they should have either CSF white count elevation or EEG with epileptic or slow wave activity involving the temporal lobes with exclusion of other causes. So if these patients have unilateral flare hyperintensities in the mesial temporal lobes, then they do not meet the definitive criteria of autoimmune limbic encephalitis. And you can see over here that antibodies are not needed to make definitive diagnosis for these patients. So these patients can be antibody negative, and if they meet all these 4 criteria, they will still be considered definitive autoimmune limbic encephalitis. And then antibody negative autoimmune encephalitis again has rapid progression or subacute onset of symptoms with memory deficit, altered mental status, or neuropsychiatric symptoms, exclusion of other well-defined syndromes of autoimmune encephalitis such as ADEM or typical limbic encephalitis. These patients obviously do not have antibodies in their serum or CSF, and they need to have 2 of these 3 criteria, which is again MRI abnormalities in the mesial temporal structures, either unilateral, bilateral, or any other evidence of inflammation on the MRI, such as demyelination, elevated CSF white count, CSF oligoclonal bands, or IgG index, or brain biopsy suggestive of inflammation. So that those are the diagnostic criteria which may be applicable to autoimmune encephalitis, and even autoimmune epilepsies. Patients will have most of these clinical features at some point during their disease. Another thing that I wanted to emphasize on was that the subacute phase of autoimmune encephalitis with seizures can last for several months. And just because these patients have seizures ongoing for several months, they may not necessarily be called autoimmune associated epilepsy. It's perhaps more appropriate to call them that autoimmune seizure disorder during this subacute phase, because the risk of development of epilepsy is overall low and is dependent on inflammation. So perhaps a reasonable follow-up would be a year before the diagnosis of autoimmune associated epilepsy can be made. At 6 months to 1 year, if these patients continue to have seizures or need sustained anti-epileptic medications, then they should be appropriately diagnosed with autoimmune associated epilepsy. So far we have discussed patients who are presenting in the acute to subacute setting with one of the autoimmune encephalitis kind of picture. These patients are more easily recognized. A lot of these patients we'll encounter in the inpatient setting. I think a bigger challenge is recognizing these chronic patients with chronic epilepsy of autoimmune origin, whom we encounter in the outpatient epilepsy setting. So chronic epilepsy of autoimmune origin or autoimmune associated epilepsy is under-recognized. It's typically refractory to treatment. The true incidence is unknown because a lot of these patients will not undergo the appropriate workup that they deserve because they're under-recognized and they may not be appropriately treated. So with that, what is the prevalence of autoimmune epilepsy among chronic epilepsy patients? So I came across a few different studies. This is a publication from 2013 that looked at 2 epilepsy adult cohorts, which included 416 epilepsy cases and 148 controls. The 416 epilepsy cases had epilepsy of unknown etiology. They were either patients with established epilepsy or newly diagnosed epilepsy, but all of them had unknown etiology of epilepsy. So all of them underwent antibody testing, and they found that antibodies were present in 11% of epilepsy patients as against only 0.6% of controls. So they concluded that as many as 11% of patients with epilepsy of unknown etiology may have antibodies in their system, signifying that these patients have autoimmune origin of epilepsy and would benefit from the appropriate workup and management along those lines. More recently, in 2017, there was a prospective study by the Mayo Clinic that included 112 established or new onset epilepsy patients, again with unknown etiology of epilepsy. All of them underwent antibody testing, and they found out that 20.5% of these patients had antibodies suggesting autoimmune cause of epilepsy. So the number is pretty high in the patients with epilepsy with unknown etiology of epilepsy who come to the outpatient clinic. Within the same study, they proposed a screening tool known as antibody prevalence in epilepsy, or APE score. It has different clinical features which are given different value with a total score of 14. These features include new onset rapidly progressive mental status changes, neuropsychiatric changes, autonomic dysfunction, viral prodrome, facial dyskinesias or faciobrachial dystonic seizures, refractory seizures, CSF findings consistent with inflammation, brain MRI showing either unilateral or bilateral mesial temporal flare hyperintensities, and presence of an underlying systemic malignancy. So basically, they propose this APE score as a screening tool in selecting patients for antibody testing. So if patients who present to the outpatient clinic on epilepsy and they have epilepsy of unknown etiology and they meet some of these criteria and their APE score, so the cutoff is at greater than equal to 4. So if the patients have an APE score based on the clinical features of greater than equal to 4, then they should undergo antibody testing and then appropriate management according to the findings. So these were the sensitivity and the specificity for this APE scoring system that was proposed in this paper. When they compared antibody positive cases with antibody negative cases, the antibody positive cases were much more likely to have the clinical characteristics that they had included in the APE score. Later in the same year, they published a retrospective analysis which validated the APE score and assessed and validated another scoring system, RIGHT score, which can be used to assess response to immunotherapy, or RIGHT stands for response to immunotherapy in epilepsy. So in this retrospective study, they looked at 262 epilepsy patients who had unknown etiology of epilepsy. When they compared antibody positive cases with antibody negative cases, again, they found out that antibody positive cases were much more likely to have the clinical characteristics that are included in the APE score, therefore validating the APE score. In addition, 77 of these patients underwent immunotherapy trial, and when they compared patients who responded to immunotherapy in terms of seizure reduction versus patients who did not respond to immunotherapy, they found out that responders also had the clinical characteristics that were included in APE score. In addition, responders were more likely to be male. They were more likely to be antibody positive, especially cell surface antibody positive, and they were more likely to have initiation of immunotherapy within 6 months of symptom onset. With that, they proposed a RIGHT scoring system, or response to immunotherapy in epilepsy, which has clinical characteristics that are included in APE score. And in addition to those, it has 2 additional features, which include early initiation of immunotherapy within 6 months of symptom onset, and detection of cell surface plasma membrane autoantibodies. So if the patients have intracellular autoantibodies, then they will not get points on the RIGHT scoring system. So the cutoff for RIGHT is greater than equal to 7. And if a patient scores greater than equal to 7 on the RIGHT score, then they are more likely to respond to immunotherapy compared to patients who have lower score. So these were the validated sensitivity and specificity of APE score in that study, and these were the sensitivity and specificity of the RIGHT score. more recently, in 2 further publications, these APE and RIGHT scores were revised to increase specificity and applicability. So now they are APE2 and RIGHT2 scores. The APE2 stands for antibody prevalence in epilepsy and encephalopathy. And the RIGHT2 stands for response to immunotherapy in epilepsy and encephalopathy. And the clinical characteristics are pretty much the same. The only difference from the original APE scores and the original RIGHT scores is that more weightage is given to fatiobrachial dystonic seizures and facial dyskinesias. The brain MRI findings were expanded from not just the mesial flare hyperintensities, but now any sort of multifocal hyperintensity in the gray matter or white matter or any other evidence of inflammation should be given score on the APE2 and RIGHT2. And the systemic cancer should be diagnosed within 5 years of neurologic symptom onset. Or if a patient had cancer diagnosed, say, 6 years before symptom onset, then they would not get points for this. So these changes, they were found to have more specificity. And the cutoffs for APE2 and RIGHT2 scores are still the same. So if a patient has an APE2 of greater than equal to 4, they should undergo antibody testing. And if a patient has a RIGHT2 score of greater than equal to 7, they are more likely to respond to immunotherapy. And if a patient has an APE2 score of greater than equal to 7, the specificity is 100% for an autoimmune etiology of epilepsy. So this is the diagnostic criteria for autoimmune epilepsy. So if in the clinical setting, the outpatient setting, we encounter a patient with epilepsy of unknown etiology, they should have their APE score calculated on the basis of clinical features, MRI, which most of these patients get, and CSF if it's available. If APE2 score is greater than equal to 4, then these patients should undergo antibody testing. If they end up being antibody positive, then they have definitive autoimmune epilepsy. If they're antibody negative or the testing is not available, then we can still consider these patients for immunotherapy trial on the basis of RIGHT score. If they have favorable outcome to immunotherapy trial with an APE score of greater than equal to 4, they probably have autoimmune epilepsy. If they lack a favorable outcome means greater than 50% seizure reduction. So if they lack a favorable outcome but APE2 score is greater than equal to 7, they still probably have autoimmune epilepsy. But if they don't have a favorable outcome, the seizures do not improve and the APE score is between 4 to 6, then they could possibly have autoimmune epilepsy, but the likelihood is low. So this is the diagnostic criteria for autoimmune epilepsy. This is just the CME code for those of you who were not here earlier. Now I'll move on to the diagnostic evaluation of if autoimmune cause is suspected. So we already discussed that these patients should have an EEG. So in the acute setting or subacute setting, obviously if they're in the hospital, these patients will undergo continuous EEG. But in the outpatient setting, they should at least have a long EEG for a few hours. An MRI brain should be done with contrast. Serological antibody testing should be done. CSF analysis should be done along with CSF antibody testing. A PET scan should be done. Other functional neuroimaging techniques could be considered on a case-to-case basis. All of these patients should undergo cancer screening with CT chest, abdomen, pelvis with contrast, and then on a case-to-case basis, other scans such as ultrasound, scrotal, transvaginal, mammogram, whole body PET CT may be pursued, depending on the patient. So EEG can be used for diagnosis and to monitor treatment response. It is abnormal in 90% of the cases, but it's non-specific. The only specific thing is extreme delta brush, whereby patients may have delta activity with superimposed burst of rhythmic beta, which we all know is classical for NMDA receptor encephalitis. But for everything else, the EEG findings may be suggestive of epileptiform activity, but they are fairly non-specific. Mesial temporal flare hyperintensity is either unilateral or bilateral are the classical MRI findings. But patients can also have multifocal flare hyperintensities compatible with demyelination and inflammation in other areas. Dynamic amygdalar enlargement may be an early radiological biomarker in a subset of patients. Basal ganglia, T1 hyperintensities are classically seen in LGI1 syndrome. GAD65 syndrome patients can have diffuse cerebral or cerebellar atrophy, and some of these patients may have negative scans as well. PET, classically in the acute setting, will show hypermetabolism in the limbic structures and the basal ganglia, but it can be normal or even hypometabolic even in the acute or active autoimmune encephalitis phase. It is a higher sensitivity than MRI early on in the disease. And the only thing specific to one disease that I could find was NMDA receptor encephalitis or epilepsy patients may have occipital lobe hypometabolism. There are other functional neuroimaging techniques such as resting state functional MRI, diffusion tensor imaging, SPECT scans, which can be used for diagnostic or prognostic values, but they are only used on a case-to-case basis and not used in all patients. So CSF obviously will be done, is typically suggestive of inflammation with elevated white cell or protein or oligoclonal band or IgG index. But in up to 60% of the patients, these may be completely normal, including those patients who respond to immunotherapy. So the absence of white cell count does not rule out autoimmune epilepsy. And a normal routine CSF analysis does not mean the patient does not have elevated IgG, or there will be an absence of CSF antibodies. So antibody testing should be done irrespective of a normal routine CSF analysis, because relevant antibodies might only be found in CSF, and the repertoire of antibodies in CSF and serum can be different, and it's generally the CSF antibodies that drive the clinical picture. And CSF antibodies correlate better with the clinical course than serum antibodies, so the current recommendation is to get both serum and CSF antibodies to avoid false negative and false positive test results. Now, that was the workup that we would do in the outpatient setting for these patients. As for the therapeutic approach, there is no consensus guideline for the treatment of these patients. It's fairly intuitive. If the patient has cancer, then that needs to go. So removal of trigger that may be causing is the first thing. Immunotherapy is the mainstay of treatment. And then in addition, most of these patients have symptomatic treatment with anti-seizure medications. So multiple studies have shown better seizure outcomes with early initiation of immunotherapy. However, randomized controlled trials to assess efficacy of immunotherapy are largely lacking. Treatment decisions are based on clinical recovery rather than antibody titers. So the only randomized controlled trial that I came across was of IVIG use in autoimmune LGI1 or Casper2 epilepsy. The trial enrolled 17 patients, and they found that 75% of the patients in the IVIG group responded with greater than 50% seizure reduction versus 22% in the placebo group, thereby proving that IVIG, in fact, is good treatment option for autoimmune epilepsy. This is just from the same study. This is a publication from 2014. It was a retrospective study, looked at 110 patients at autoimmune epilepsy clinic, and 29 of these patients underwent immunotherapy trials, and the study showed that early immunotherapy has favorable outcomes. So in this study, the patients who responded, they had shorter duration of seizures at the time of treatment, so they were started on immunotherapy early on. They were more likely to have multiple seizure types, and they were more likely to have plasma or surface membrane antibodies. So immunotherapy includes first line or acute phase treatment, which can be done with high-dose IVIG, high-dose IV steroids, IVIG, or Plex. They can be used alone or in combination with a 6 to 12-week trials in the outpatient setting. So typically 1 gram of methylprednisone is used daily for 3 to 5 days, then once a week for 6 weeks, and then once every 2 weeks for 6 weeks. And with that, we'll give vitamin D, calcium supplementation, Bactrim prophylaxis, and the usual stuff. The IVIG, it's the same dose that we used in the inpatient setting, 0.4 grams per kg daily for 3 to 5 days, then the same dose weekly for 6 weeks, then every 2 weeks for 6 weeks. Plex is typically given in 5 to 7 cycles, one exchange every alternate day for 10 to 14 days. So second-line immunotherapeutic agents may be considered for cases who are refractory to first line. If APE2 score is greater than or equal to 4, or the patient is antibody positive, but the right score predicts poor response to initial immunotherapy, early use of second-line agents may be considered. And those agents include rituximab, cyclophosphamide, mycophenolate, azathioprine, bortezomib, and tocilizumab. So these are the ones that are typically used as second-line agents. So one may ask, if the patient has failed initial first-line immunotherapy, what are the chances that they will respond to second-line immunotherapy? This is a prospective study that included 41 adult patients. They underwent first-line immunotherapy trials, and 51% of these patients became seizure-free to first-line immunotherapy. Of the patients who failed initial immunotherapy, 12 patients got rituximab, and 8 out of these patients, these 12 patients, so 66.6% of these patients became seizure-free, thereby showing that patients who are failing initial immunotherapy may still do really well with second-line immunotherapeutic agents. This is just redemonstrating the same thing from that study. Then this is a cohort of 185 patients who were non-responsive to first-line treatment, were then treated with rituximab. Around 50% of these patients responded to rituximab, but then 91 of these patients had inadequate response to standard rituximab regimen. So these patients were like super refractory. They didn't respond to first line, they didn't respond to rituximab. So within these 91 patients, 30 of them got treated with tocilizumab, which is an IL-6 receptor monoclonal antibody. 31 of these patients underwent additional monthly rituximab, and 30 underwent observation. And they found out that 19 out of 30 patients who underwent tocilizumab treatment had favorable outcomes at 1 month. And 17 of these 19 patients who had favorable outcome at 1 month had sustained long-term favorable response from tocilizumab. So it is one of the upcoming treatments which can be used in super refractory cases, especially if the patients have IL-6 elevated in their blood. So then patients are typically transitioned to chronic or maintenance immunotherapy to prevent disease progression or relapse. So response is typically assessed during weeks 6 to 12 to a single first-line therapy. If it's ineffective or not tolerated, you may want to switch to another first line. Once a therapy is deemed successful, the response can be reassessed in 6 to 12 weeks. If there is evidence of response, then the dosage intervals can be increased. The patients can be given chronic IVIG or Plex once every 2 to 4 weeks for maintenance therapy, or they can be transitioned to oral chronic immunosuppression with mycophenolate or azathioprine. And then if the patients have not had any relapse for 1 to 2 years, withdrawal could be considered. So for intracellular antibody positive epilepsies, because they are T-cell mediated, they are more likely to respond to broad spectrum immunosuppressive agents such as cyclophosphamide, which is a cytotoxic agent, which lyses lymphocytes, or mycophenolate, which can inhibit T and B cell production. As against surface antibody-mediated epilepsies, in which cases antibodies are pathogenic. So the treatment goal is reducing the antibody production, and the treatment regimens should be selected accordingly, such as rituximab, which is a monoclonal antibody to CD20 antigen, which results in B cell depletion, or Plex, which removes antibodies, would be the more suitable options for these epilepsies. Anti-epileptic drugs may be used for symptomatic treatment. However, these patients we know are usually refractory to AED. These seizure medications are used along with immunotherapy. And a study has shown that sodium channel blockers tend to have a better outcome compared to Keppra, because carbamazepine, oxcarb, carbamazepine have been shown to reduce levels of inflammatory cytokines in healthy adults. So sodium channel blockers are the preferred treatment in these patients. Treatment response can be monitored by seizure frequency, neuroexam, including mental status, MOCA testing, frontal cognitive testing, EEG, MRI, or PET scans may be done. Antibody titers can be done, but they have a poor predictive relationship with treatment response. Epilepsy surgery may be considered for patients who are failing immunotherapy, but these patients have worse outcomes after surgery compared to other drug-refractory epilepsies. These are just some doses of different immunotherapeutic agents. This is a good table that I found, which has all the mechanisms of action, adverse effects, and monitoring that needs to be done with these immunotherapeutic agents, but I'm not going to go into the detail of it in the interest of time. And just one last thing with treatment algorithm. So if patients have epilepsy of unknown etiology, they should have an APE score calculated, APE2 score calculated. If it's greater than or equal to 4, they should undergo antibody testing, and then depending on the results and the clinical presentation, they can undergo appropriate tumor screening and tumor testing, and then simultaneously they should undergo immunotherapy trial with either IV steroids, IVIG, or Plex, and then response should be assessed in a few weeks. If they are responding, then they can be transitioned to chronic immunosuppressive therapy. If they're not responding, another first-line agent or a second-line agent may be considered, and whenever they respond, they can be transitioned to chronic maintenance immunotherapy. So for prognosis, there is a low overall risk of epilepsy, but there are certain characteristics that predict a worse prognosis. So in LGI1 encephalitis or higher CSF LGI1 IgG4 subclass titers correlate with worse outcomes. For NMDA receptor encephalitis, presence of extreme delta brush on EEG predicts prolonged course. And there's a scoring system that is used for NMDA receptor encephalitis, and if this NEOS score, and if the patient has high NEOS score, they tend to have poor functional status at 1 year. Follow-up should be with an epileptologist and a neuroimmunologist. And chronic refractory epilepsy typically develops if there is irreversible cortical damage or persistent inflammation. MRI with contrast, PET, and CSF may be helpful in guiding treatment. So with that, that is pretty much all that I have. The take-home message from the talk is that autoimmune encephalitis is not synonymous with autoimmune-associated epilepsy. Acute symptomatic seizure secondary to autoimmune encephalitis does not mean that the patient has autoimmune-associated epilepsy. Subacute autoimmune seizure disorder can last up to 6 months to a year, but the risk of chronic epilepsy is relatively low. Prevalence of antibody-positive epilepsy among epilepsies of unknown etiology is 10 to 20% and accounts for 5 to 7% of all epilepsies. So this must be kept in mind in the chronic outpatient setting. It is important to distinguish between surface antibodies and intracellular antibodies, autoimmune epilepsies, but because they will drive the prognosis and guide the treatment. APE2 is a useful screening tool in the outpatient setting to identify epilepsy patients of unknown etiology who should undergo antibody testing. RIGHT2 is a useful score to identify patients who will respond to immunotherapy. Keep a low threshold for switching to alternate first-line or second-line agents in patients who fail initial immunotherapy, and long-term follow-up is really important. Thank you so much for giving me this opportunity, and thank you so much for listening to this. Any questions?
Thank you very much. Can you hear me?
Yes, yes.
This is Dr. Friedland. Thank you for your outstanding presentation. As you said, the trigger for autoimmunity can come from an antigen that we have from our own bodies. However, our largest environmental exposure is to the microbiota, which are bacteria, which actually, there are more of them, there are more antigens in these cells perhaps than we have ourselves. So there could be sources of molecular mimicry residing in the metagenome. Furthermore, the microbiota are documented to have important influences on the immune system. So if there is an immune process, its origin and severity could be modulated by the microbiota. And the best model for this might be MS as well as NMO. Both have been shown to have important influences in the microbiota. I would recommend, if you look into the work of Stan Hazen, Hazen, at the Cleveland Clinic, he's done remarkable things about microbial products in the gut and influence on heart disease. Thank you very much.
Yeah, I agree. Microbes have a huge role. So either viruses or tumors or even other microbes can be triggers for autoimmunity in these patients. So that's really true. Thanks.
Thank you.
Hello, can you hear me?
Yes.
Yeah, so again, I echo Dr. Friedland's sentiments. This was a really superb talk. Thank you. So my question for you has to do with the subacute manifestations or presentation of a antibody-mediated epilepsy. And how severe are these patients usually in terms of their clinical presentation, or how mild can they be in terms of their clinical presentation, so that, is the clinical presentation always very clear that you're dealing with something pretty significant and dramatic, or can it sometimes be not as severe in its manifestations?
So I think that is really the challenge. In the acute setting, they tend to have very dramatic presentations. And for certain kinds of syndromes, such as NMDA receptor encephalitis, they tend to have very severe syndromes for several months. And it's sort of hard to miss them. But when these patients present in the more subacute to chronic setting in the outpatient epilepsy clinic, they may have, I think the most important thing is how their onset of epilepsy was. That is probably the most important part of history, because at that time, they may not have overt neuropsychiatric symptoms when they're presenting, because a lot of chronic epilepsy patients have memory deficits anyway. And they may not have other dramatic symptoms, like you said. So I would say they can be pretty mild. It's a huge spectrum, and they can be more dramatic. But the more dramatic ones are typically in the more acute to subacute setting rather than the subacute to chronic setting. So I think a good history will be a good guide. If they had their symptom onset 6 months ago, and at that time it was subacute to acute, and it was dramatic, and they required a hospitalization, it was very sudden, they couldn't identify a clear trigger, or maybe there was a viral prodrome. I think with those kind of things, it could be an indicator. Get them tested, even if their current presenting symptoms are mild. And then the severity of symptoms varies from syndrome to syndrome. So some of them may be very severe, some of them would be milder. So I think the biggest challenge is that in the chronic epilepsy settings, many of these patients may not have dramatic symptoms. And because memory deficits are frequently encountered in our epilepsy patients anyway, they may just go unnoticed, and therefore these patients may not get the appropriate workup. So I think a good history is what we need, because most of these patients, even if they don't have a dramatic presentation in the subacute to chronic setting, they tend to have a pretty dramatic acute onset of symptoms when their epilepsy or seizure started.
Great, thank you.
Ifrah, this is Joseph Niemann. Can you hear me?
Yes.
Hi, thanks. That's a great presentation, a really wonderful coverage of this topic. I'm curious, at the risk of sounding surgery-centric, we had a patient recently who had a documented autoimmune epilepsy, failed all of the therapies that you've mentioned, and continued to have very severe seizures, and life was badly affected by it. And we've considered surgery. And I'm curious what your thoughts are about how you might approach surgery. Is it ever appropriate? We are certainly aware that she's at risk of having another seizure focus appear.
Yeah.
What's your thought on that?
So surgery, let me show you a couple of slides on that. So the surgery is appropriate in the chronic setting, obviously. So this is a good slide for that. So you can see when they are in the acute to subacute phase, then immunotherapy and anti-seizure medications are the way to go. Surgery is more appropriate when they're already sort of entered the autoimmune associated epilepsy. And granted, there's no like timeline cutoff for when these patients should undergo surgery, but if they have developed a lesion on the MRI, for example, if they already have hippocampal sclerosis, or if they have clear evidence of irreversible damage somewhere on the MRI, then surgery is the way to go. Because clearly, if they have already damaged their mesial temporal structures, then nothing is going to help them except surgery. This one study that I came across for surgery patients was, that these patients tend to, this is a 2015 publication, I believe, these patients tend to do worse after surgery when compared to other drug refractory epilepsy. But again, if they're not responding to any other, they're not responding to immunotherapy, they're not responding to anti-seizure medications, then obviously surgery is the only option you are left with. But I would say in the acute setting, early initiation of immunotherapy is going to be the most useful thing. In the subacute and to chronic setting, if they were not appropriately managed early on, and if they have already developed evidence of irreversible damage on the imaging, then surgery is the way to go. And then if they are very refractory for like a very long time. But these patients can have no, and then intracellular antibody patients should be considered more for surgery rather than surface antibodies, because surface antibody syndrome patients such as NMDA receptor encephalitis can have their subacute course lasting for a year, and then they can completely recover as long as there is no evidence on the MRI of an irreversible damage. So that should be kept in mind, that if they have surface antibodies, I would still give them a shot with immunotherapy, wait it out, and avoid surgery in those cases. And for intracellular antibody syndromes, perhaps surgery should be considered earlier than later, especially with irreversible damage on the imaging.
Interesting.
Yep.
All right. Thank you very much. Good answer. Appreciate it.
Thank you, Dr. Zawar. That was very good. Very helpful
Thank you.
for all of us.
Thank you. Thank you. So,
Does
thanks a
anybody
lot.
have any other questions?
Thanks a lot for this opportunity.
Absolutely.
Have a
It's great talking to you again. We'll talk soon. We'll
great
be in touch.
Thank you for joining
Thank
us. It
you.
was a pleasure
Thanks.
to hear your talk.
Have a great day.
You too.
You
Thanks very
too.
much.
Bye.
Thank you.
Thanks, everybody.
Bye-bye.